So today's session is a great session about symptom management strategies. And this really came about because we get questions from families, but we also see families chatting with one another, especially in support for FOP, the Facebook group, about different ways that they are using to manage our symptoms. And we thought, let's just bring a session to the family gathering and hear from the experts about what are some of the best ways that they are seeing patients and families managing symptoms of FOP. So we're going to have a panel discussion today. It's going to start with 2 presentations, and then we'll be going into a Q&A session. So our first speaker today is Dr. Chris Scott, and he is Associate Professor and Head of Pediatric Rheumatology at the Red Cross War Memorial Children's Hospital in Cape Town. I mentioned the FOP Africa meeting earlier. He was one of the main organizers of that meeting that was held in October, and he is also very actively involved in the International Clinical Council on FOP and the Registry Medical Advisory Board. So with that, we'll have Dr. Scott come to the stage.
Thanks so much, Michelle. Thanks, everyone. It's always nice to be able to speak to you. So the talk I'm going to give is sort of based around some of the practicalities of how you access medicine and to reflect a bit on how it is that medicines are available in some parts of the world and they're not available in others, and why are they paid for in some parts of the world and not paid for in others. I think that's a real on-the-ground issue for people with FOP, and it's something that I get asked a lot, being not from the US or Canada, where the first drugs have been approved. The question is always, why can't we get these drugs? So it's really a reflection that it's got a bit of a global perspective, and I hope you'll find something to get excited about or to think about. And I guess at the end of it, my message is going to be that we all need to work together to be able to provide access to all of these therapies to people all over the world. So this is literally where we're at. Everyone can talk on social media. Everyone can see one another. We've got people in Uganda who are friends with people in the US, and there's this discussion: why can you access this therapy, and why will your system pay for this therapy, or why is it even available in your country and not in mine? And I think it bears explaining a little bit. So the first thing that needs to happen is, obviously, we need to have a drug that we know works for FOP. And that can only happen through a clinical trial. And as we know, there's only, thus far, one drug that's made it all the way through clinical trials to the point where it's able to have been approved in 3 countries now. So you need a drug that works, then you need a drug that's approved, and those 2 things are obviously different. When I say approved, it needs to be approved by the jurisdiction in which you want to use that drug. Then you need it to be available, and by saying that, I mean it needs to be something that someone's going to pay for, that either you could afford or that your healthcare funder can afford, so it needs to be available. And then after that, it needs to be right for you. It mightn't be that you yourself have a particular contraindication to a drug, or a reason why you can't use a drug, or you have a sensitivity to a drug, an allergy to one of the components or something. So at that point, it still needs to be right for you. And then you actually need a whole ecosystem of people who can actually give you the drug and make sure that you use it safely. So it's really not as simple as, there's a medicine for FOP, let's give it to everybody in the world. It just doesn't work that way. The system is actually quite complex. As you know, and you've seen several of this versions of this type of slide, there's this discovery and development phase, which can take 10, 20, 30 years for a drug to be imagined, and then discovered, and then tested in animals, and then tested in humans, and then tested in more humans, etc., until it's tested in the group that you want to use it in. And bearing in mind that in FOP, we want to intervene in children, because that's where the battle for FOP is won and lost. That pushes that timeline out even further. As many of you have said, we'll only ever expose our children to medications once we have absolutely minimized the risk to be able to test and make sure these medicines work in children. So that just stretches out the timeline. It just takes time to do these things. Then there's that involved the preclinical research and the clinical research, and then there's the government review phase. Now, every government in the world has a responsibility to its citizens to review the medicines that are made available in that country. Those of you who live in Canada and the US and Europe have extremely robust and actually very fast-moving government regulatory agencies. It might seem slow if you're waiting for a drug desperately for your whole life, but usually these three drug agencies, regulatory, governmentary bodies are actually the fastest in the world at getting this kind of stuff done. And so a lot of the world depends on or follows the lead to some extent of the USA and Canada and the EU in approving these drugs. But it doesn't mean to say that just because the FDA has approved something, it's automatically approved in South Korea or Australia or South Africa or wherever. So that needs to be borne in mind. And then the last thing that people have to remember is that even once you get a drug that's been approved in your country by an agency and it's being used, there's ongoing monitoring of that medication. And if that's called post-market safety monitoring. And it could be that some side effects take 10 or 15 or 20 years to emerge. And it could be the drug is approved and everyone's happy and many people are accessing the therapy, and 10 years later we find out there was a problem, and it's happened many times that a drug has been withdrawn from the market because of post-market surveillance. For instance, I used to be on a drug called Vioxx, a therapy for an anti-inflammatory medication, and that was stopped in the early 2000s because of a risk of bowel cancer that was identified. So a drug can also be withdrawn because these regulators are actually keeping a close eye on these things. You guys laughing about bowel cancer? That's a bit weird. So every country has its own regulatory authority. So I've just given you some examples here, and they've all got different names, but they all are fiercely independent, actually. They don't really talk to one another. They make their own minds up because they have responsibility to their citizens to be able to do this. So just reflecting on what this process costs, it's extremely expensive. This paper cited a number of $2.6 billion per drug to be able to make the whole journey from being developed to being able to be prescribed to people in a country. $2.6 billion is not a small amount of money. And it's only 1 in 1,000 drugs that really make it through all of that gambit, that can follow the whole process and get right to the end where people are able to prescribe it. So it's an expensive and highly regulated area. So here, for instance, is the FDA's method of reviewing things. And you can see, if you look at that little one at the bottom, the FDA, the drug's already registered even before any testing starts. On animals or humans, when the drug starts developing, already you have to say to the FDA, listen, we've got this molecule, we want to start developing it, and we're going to develop it in this way for this particular reason. That process, that monitoring starts then already. Then you have the phase 1 and phase 2 and phase 3 trials that you've all heard about. And then comes the point where you have to submit to the NDA for an indication. They then put together a panel. That panel is kind of like a jury. It doesn't necessarily include only FOP experts. It doesn't necessarily even include people living with FOP. It might include one of those two categories, but often it's people who really have heard about FOP for the first time during this process. And the reason these panels are sort of put together like this is because they want independent-minded people to be able to look at this without skin in the game, who can analyze the evidence and the science for exactly what it is and make a decision that is fair to everybody and that is transparent and that people can question in later years and say, was this the right decision or not? So these panels are like juries, and juries are selected. You guys know more about juries than I do. We don't have those in South Africa, but juries are selected, as far as I can tell from LA law, by by interviewing people and deciding that these people are independent and they're not going to be unduly influenced by and make a decision which is biased in some way or another. So this jury then gets together, and it sometimes feels to us as clinicians quite frustrating, like we're FOP experts. We live, breathe, and think FOP, and here's a committee that might include some FOP experts, but a lot of the people there have no experience of managing FOP. And that's an important balance in the system, but it does sometimes feel frustrating to us. Once that's all done, there are several opportunities to review, and what the FDA does, which is a little different to what the European Medicines Agency does, is it also takes consideration. There's an advisory board who think on this, who look at every single detail of every single trial, to the point where they can even come to the company that have done the study on the drug, take all of the data that they've collected, like the raw data, like actual numbers that they've written down, and say, okay, you've showed us your results, but we're going to reanalyze these in our own way and look at it with our own statisticians and make sure that all the maths you've done is correct, et cetera, et cetera. And then they decide, based on their own analysis of that information, whether or not they can draw the same conclusion that you did when you published, or the company did when they published their paper. But the other thing that the FDA does is they actually have an open, transparent process where the public is able to give comment and to actually have a say in the decision, and to try and give some insight to the panel as to what the real life problems are of the people that are hoping this drug will be approved or not. The EU approval system is similar. There's a panel that's put together. They've got two, I've forgotten the word now, but they appoint two lead people to lead the constitution of these panels and to look at all these medications. And they have several steps. And the EU obviously is a number of countries combined together. So there are two ways. There's the centralized procedure where you go straight to the EU and you ask the EU to approve a drug, in which case it's then approved not for any specific country, but for all the countries in the EU. Or you can go and say, we've got a drug that we have already approved in, say, Germany or in France, and now we would like the EU to consider approving this drug for all the other countries in Europe. So there are those two routes, but in essence, they work the same in the end. But the EU system is slightly different in that there's not as much opportunity for public discourse in terms of getting patients to reflect on this. And then, just for argument's sake, or just for another example, I've thrown in the NHS's system. They've got the drug discovery, the lab testing, the market authorization by the Health Regulation Authority, the initial, and then there's the process of the price being set by the manufacturer, for instance. Then it's approved by a committee called the NICE committee, the National Institute for Clinical Excellence, I think. Is that right, Richard? Thank you. And they make a decision on, so great, we've got the science that this drug works. Now we've got the price of this drug. Is it worth it for our country to pay this amount of money for this drug, for this effect? For instance, if a cancer therapy has been approved, NICE has to decide, are we going to pay $16 million a year for a drug that prolongs the average person with cancer, with lung cancer's life by 2 months? So that becomes a difficult decision, and that's the kind of thing that then gets reflected on, and they decide whether they as a country can actually afford to pay for this. So and that process plays out in many parts of the world in similar ways, but obviously with different particularities. So if one looks at palovarotene then, for instance, which has been approved, you can see it received orphan drug designation already in 2014. In 2016, the EU and the USA authorities got together and said, look, we really have to do something about rare diseases. It's difficult to develop drugs for rare diseases. There's really very little motivation for companies to really develop medicines for rare diseases. So they created some rules and regulations that made it a little bit easier and a little bit more attractive for companies to actually work in rare diseases, to develop drugs so that people could have access to therapies for rare diseases. Palovarotene was then approved first by Canada in January of 2022. The FDA Advisory Committee initially looked at the data and shortly after that and asked for more data and asked to analyze the data themselves. They had another meeting at which they reviewed the data again, and they still weren't quite satisfied, and they asked for another review of the data and some reanalysis. In that time, the paper on which palovarotene, in which the palovarotene results were presented was published. The EU had a look at the same data, had obviously the same process, and for various reasons that I don't want to go into, decided initially to refuse it. They re-examined it and they refused it again. And then eventually the European Commission rejected the palovarotene application. But just at the same time, though, the FDA Advisory Committee had a big meeting. Many of you might have been there. Certainly many people from the FOP Association, International FOP Association were there. And they decided to recommend that palovarotene be approved. And the FDA then eventually approved it for use in the USA as well. So you can see that different systems can have different responses to the same data. And that's because there are different approaches, different sets of panel members, different ways of looking at the data, different priorities. It's a very complex thing, and not everybody looks at the same information and makes the same decision. Just like all of us, we all want to buy a car. We don't all look at all look at cars and all buy the same car, right? We have different approaches to these things. So what do you do in the meantime when there's a medicine that's available somewhere and it's not available elsewhere? Well, a lot of the time, and for most of FOP's history, all of FOP's history, we've been using drugs like prednisone and mast cell stabilizers and bisphosphonates and other things, but we've been using them off-label to try and manage the symptoms of FOP. And I just wanted to say that because off-label is what it means when you use a drug which for an indication for which it hasn't been approved. So for something to be on label, the FDA or the EMA has to say, this is the medicine, this is when you can use it, these are the people in whom you can use it, these are the side effects that you might consider, that you might expect when you're using it, and if you use it according to this prescription, the label that's in the little box that you get when you get your medicine, that's on label. Everything else is off label. And so, for instance, if you 70% of medicines that we use in children are actually off-label, because in the development of those medicines, children for many, many years weren't involved in clinical trials. It was considered not good, necessary to have children in clinical trials. And so a lot of what we use in children, even things that you use every single day, are off-label for children because they're not actually on the FDA-approved label for an indication. So we're used to using that. But the gold standard is actually to have the label, because then you know exactly what you're dealing with, and you know you've got a therapy that has been approved for a specific indication and it will work. So off-label isn't necessarily a swear word, but it's certainly not as good as having a drug for which is on label. The other issue is that a drug that's on label actually gets paid for by, usually, more easily by funders, because funders will say, well, you can't just, what's the evidence that you can use, what's the evidence that you can use castor oil in FOP? We don't have any evidence, so therefore we're not going to pay for you to be able to use castor oil in FOP because we don't know that it even works, so why should we pay for it? So funders rely on the label as a security that the agent that you're being used is being used safely and for the right indication. And so that's why it's important to have things on label. It also means that the whole system's been followed and that the drug's been tested and that the side effect profile of the medicine is clear and so on and so forth. So this is complicated and it's difficult, and there are many ways that you can if you're not in a country where you've got access to these medicines, or you're just very confused about what is available in your country and what's not available, you can reach out to your local doctors, you can reach out to the to FOP, you can reach out to the ICC. We don't have representatives necessarily from every country, but we generally have contacts in most countries, and if we don't know, we'll try and find someone who can figure out, if you're living in whatever country you're from, which medications are available or allowed to be used in your country in this context and how they're funded, etc. But you can also, in areas where there are no FOP experts or FOP bodies or national organizations, you can reach out to rare disease societies or academic physicians and so on. That green plant there, which looks suspiciously like a marijuana plant, which is unintentional, means it's got nothing to do with marijuana. It means that you can plant the seed. Sometimes you'll be the only person in your country with this problem, with this need to access this therapy, who knows that this therapy might be available. So you might have to be the person to plant that seed and grow that plant. And it's not marijuana. Okay. So once it's registered, is it available? So we run into this a lot, right? I mean, there are medicines that are registered that are just, for many reasons, not available. So the first thing is the state has to decide on the cost benefit. Is the state prepared to pay this much for this indication for that individual? We all have a right to health care, but the governments have a right to manage their funds to give the best for the most people, right? So they might not be able to afford something that treats a small number of patients, especially if it gives them a limited benefit. And the wealthier the country, the less likely this is to be a problem. But there are more countries in the world that are not wealthy than there are those that are wealthy. So it's likely to be a problem in most parts of the world. Many countries have a health insurance system, which is not government funded, and the health insurance, those funders are, they're in the game usually because they manage their finances really well and they need to look after their finances. Otherwise, they've got no product to offer and nobody gets any medicine. So they might also not pay for a very expensive therapy, especially if the benefit isn't clear. And in many places in the world, people have to self-fund this kind of therapy. And for instance, in most of Africa, there's very little national insurance, very little health insurance, and people have to pay out of pocket for almost all of their healthcare expenses. And there's even this concept of healthcare, I'm forgetting the word, but people can, there's a very real risk that people bankrupt themselves and future generations of their family trying to access therapy sometimes. And so the cost of therapies is a major issue. And what influences the cost of therapies? Obviously, the cost of the development of the drug, as you saw, is very, very high. And because that cost is high, and because there are very few patients, the cost of recovering that cost of developing the drug is also very high. And this remains, this is a problem with the way the world is put together. But one of the ways that companies are able to try and make back the money that they've invested in creating this very important therapy is to have a patent. And patent laws are different all over the world. So a patent means that the company will have the sole right to be able to make that drug and supply it for a specific amount of time. But that specific amount of time varies across the world. For instance, in a country like India, patent laws are very relaxed, and people can, and patents are very quickly lost, and the companies don't have a long period to make their patents. But in some places like South Africa, patents can last for many, many years, even decades, and it's and that controls the price of medication. So in South Africa, for instance, we had the experience with antiretrovirals that were extremely expensive. There you can see the price of antiretrovirals when in June of 2000 was $1,000 per patient. I don't know exactly what the per year, $1,000 per patient per year for antiretrovirals. And of course, we had a huge HIV pandemic, and it was only when the generics started coming on you could see how the price of the original drug plummeted. And nowadays it costs under $10 for the same medicine to treat HIV. So it shows you the effect and the power of patents on this. It's the way the system is, but it's worth knowing these things when you consider why drugs cost what they do and what the future might look like once we have more than one drug or once patents expire. So where do you find a doctor who can help with all of this? There are few FOP experts in the world. You might not be lucky enough to live in a country with one of those. It's important to start locally, and the best place to find a local doctor and to turn them into an FOP expert is usually to go to an academic center. To find one doctor, even if they only have one other FOP patient, if you're the second one, that doctor is the closest thing to an FOP expert that you have. It's often good to approach multidisciplinary teams, and I'm a pediatrician, so I put there pediatric because hopefully everyone is diagnosed early on, and to find a multidisciplinary academic team, you'd usually find someone who's able to take this on. By the way that academic units are structured and put together, people are actually interested in developing new areas of skill. So this might be a good approach. And you might ask another FOP doctor in another area to send you to someone that they know. Even if that person's not an FOP expert, they might be able to refer someone that they think might be interested in becoming one. And so if no one in your area knows anything about FOP, it's sometimes up to you to find a doctor or a healthcare worker who will support you, and then to develop them into an FOP expert. But it is key that every single one of us has a local physician. It's very difficult to do healthcare across thousands of kilometers. So even if you have an FOP expert who's absolutely willing to take your call day and night, it is important to get someone who's local, because the day will come when you need local advice and local help very quickly. And you can help develop that local person, and that helps the whole community, actually. So you've got to work on that relationship. You've got to build a relationship. You've got to keep going back to the same doctor. It doesn't help just going from doctor to doctor to doctor. It helps a little bit to sort of latch onto someone and massage them into what you need them to be in terms of being an FOP doctor. And I can't stress again how important it is to have someone who's local. And you can ask within the community, and you can ask other FOP experts to help you in this process. And the last thing I want to say about drug development and so on is there are two other ways to access therapies. The one is to actually participate in a clinical trial. Now, clinical trials are not therapy, but should clinical trials be successful, in many countries there's a rule that if the trial is successful and the drug seems to be working, that the company has a responsibility to keep you on the medicine, because they can't come into your country, test the medicine on you, and go out and then sell the medicine in another country and leave you with nothing. So many countries have that rule. South Africa certainly does. But here's a study that shows that many times studies happen in countries, and the drug that is tested in that country is often not marketed in that country. So you can see the percentage of drugs in Africa. If you look at just those blue little blocks on the bottom line, Africa and Asia, very few drugs that are tested in Africa and Asia actually ever get marketed in Africa and Asia. And the reasons are obvious. There aren't big markets because there's not a lot of money there. But which is why many countries have this rule that if you're participating in a clinical trial, they expect the company to at least provide you, the person who's put your body on the line for this trial, to have access to the therapy for going forward. So post-trial access becomes one way to get therapy if you're in a place where you're lucky enough to be able to participate in the clinical trial. And there are also mechanisms of compassionate use. For instance, in South Africa, the company has to come to the country. I'm sorry, my time is up. The company has to come to the country and register the drug. But if they're not coming to your country, you can actually apply to the government to say, look, I just want registration for this drug for me, and these are the conditions under which I'm going to use it, and this drug is also registered in the US, etc. So that mechanism is possible in many countries, and it's worth inquiring about that for your own country. In the end, the message is, if we're going to help all the people with FOP in the world, we actually have to understand all these things and all work together to be able to provide access to all of these therapies to everyone. The world is unfair, but we can all work together to make it a little bit less unfair. And it takes all of us. The FOP community, pharma plays an incredibly important role, obviously, in developing these drugs and making them available. But patient organizations, funders, the governments, doctors, healthcare workers, we all have to work together to try and give it as much access to as many people as possible once we have therapies that are proven to work. So I'd like to thank you, and thanks for the opportunity to speak to you, and thanks FOP for bringing me here, and thanks. I need to acknowledge the ICC for all the work they've done in this whole space of drug development, and to the industry who are responsible for bringing us these drugs. Thanks very much.
Okay, so back with us again virtually is Dr. Mona Al-Muqaddam, and I think she's there. There is a picture of her, and she's going to be joining us. So many of you know her as Dr. Mona. She is an adult endocrinologist in the Division of Endocrinology, Diabetes, and Metabolism at the University of Pennsylvania at the Penn Bone Center. And she is a fabulous resource, and she's going to dive in and talk a little bit more about some of the things we're chatting with each other about on Facebook. So Mona, I'll let you start, and I'll just stand up here to confirm that we can hear you.
Perfect. Can you hear me?
We can hear you.
Perfect. Thank
Okay,
you
it's
for
yours.
doing that. Perfect. Yesterday I had to wait for the laughter to know that people could hear me, so this is good. All right. So yeah, I think Chris, thank you so much for this wonderful introduction. And I listening to Chris and everything that he's talked about, that's really what's most important, right? Having a local doctor that you can talk to, using us as a resource to help guide some of those things, and understanding that drug development takes a really long time. And so what I'm going to be talking about right now is basically what to do now, right? And this is what's been discussed on Facebook. A lot of people share what they have been on or what their children are on, and so so that's going to be really the focus of my talk. Can we advance? Okay, so it's going to be the off-label use of medications in FOP. And so Chris did a wonderful presentation and allowing you to understand what it means when a drug is off-label. Next slide. I have a lot of disclosures, right? I'm a PI on clinical trials, I'm in the ICC, but I think for the sake of this talk, the most important thing to understand is that you really need to talk to your local doctors before discussing or initiating any new drugs. And the information that I'm going to provide today is by no means comprehensive. I'm not including all the side effects that could happen. I'm not including any of the drug interactions that could happen with these medications. And so it's really, really important that, again, you have this local doctor that you're going to talk to so that you can understand, in your case, what is the potential benefit? In your case, what is the potential risk of being on this medication? Do you have any other health issues that would make it a contraindication for you to take this medication? What medications are you on that could potentially interact and cause problems? As well as, talking about what is the local availability where you're at, what is the cost of that? As Chris mentioned, because the drugs that we're prescribing are usually in an off-label way, the insurance companies might not approve to pay for those drugs. I think Chris said it in a much milder way. My perspective, sometimes I feel the insurance companies are trying to find a reason not to pay for something. And so when we're prescribing something as an off-label, they say this is experimental and we're not going to pay for it. Most of the drugs that I'm going to be discussing today are available in the treatment guidelines that are available on the ICCFOP.org website. As Fred Kaplan mentioned yesterday, he's actively working on updating these guidelines. So we're all actively updating these guidelines. We hope they'll be available early next year, but please do go back to the website to get the most updated guidelines. Next slide. Historically, the way we have classified medications used in FOP are as three classes. Class 1 is what we think of as almost like standard of care, that most of our patients have been on these medications at some point. And it's really to treat the swelling and the pain that is associated with FOP. And these medications are around, they're used a lot, and they're relatively safe. The most commonly used one is the glucocorticoids or the prednisone that we use in the setting of an acute flare-up in a major joint or with major trauma, or if someone's planned to get surgery. And then also the NSAIDs, which are also used to treat pain. And these are the non-steroidal anti-inflammatory drugs. So these are the class 1. Class 2 medications are basically medications that are currently approved for the treatment of other disorders. The medications are out and a lot of patients have been on them. So we have clinical trials in different diseases. And so we understand better the side effect profile of these medications. We understand better how to dose these medications in different diseases. And based on how these drugs work, whether it's because they decrease inflammation or they decrease mast cells or they decrease bone formation, we think that maybe because of the mechanism of the way the drug works, and with our understanding of how FOP works, that these medications could potentially help. Now, in the class 2 medications, the data in FOP is very little, if any. Some of it could be just from patients reporting that they tried this drug and it worked for them. Some of it could be because it's published data where a doctor has tried a certain drug and they felt that it worked for them. Or because of the mechanism, and we think that maybe it would work, and it was tried in an FOP mouse model, but we don't have any human studies to demonstrate that it works. But some examples that are in the class 2 are leukotriene inhibitors, and these are medications that are used like in asthma. Mast cell stabilizers like cromolyn, which is also used in mast cell disorders, and medications like bisphosphonates, which is pemidronate or zoledronic acid, imatinib, and interleukin-1 receptor antagonists. And so the ones that are bolded are the ones that are going to be I'm going to be talking about today. Class 3 medications are medications that are actively being investigated as a potential therapy for FOP. I will not be talking about any of the investigational drugs. As you can see in that list, we had the palovarotene, which is the retinoic acid receptor gamma agonist, so the RAR gamma agonist. And Ed Chow did a really wonderful talk yesterday talking about palovarotene, and Chris also spoke about it today. So I will not be talking about palovarotene or any of the drugs that are currently in clinical trials. Next slide. So let's start with Celebrex. And the reason why I chose Celebrex is because that one apparently has been on Facebook a lot. So the reason why they're on my talk today is because they've been featured on Facebook. And so currently Celebrex, if you look at the label or the indication for its use, it's used for acute pain, for arthritis, whether it's due to osteoarthritis or due to inflammation like rheumatoid arthritis or other inflammatory forms of arthritis. It's also used for migraines as well as pain with menstruation. The advantage of Celebrex is that first, it's an oral pill, so it's not an injection, and so that's easy to take. It can be sprinkled with food. It's available over the counter, and it's also approved in adults as well as children. In children ages 2 and above, it's usually weight-based. In adult, the dose could be 100 milligrams once daily or twice daily, but no more than 400 milligrams daily. There are potential side effects with this medication. So even though some of the non-steroidals you can get over the counter, there are side effects from these medications. So medications that are also in the same class of the non-steroidals would be ibuprofen, Motrin, Aleve. So these are all the same class of medications. As Chris mentioned, there was Vioxx before. So Vioxx was also given in FOP patients, and it seemed to help with their pain. And Fred might be able to give more historical information on Vioxx. but that was withdrawn from the market because of concerns of increased risks of cardiovascular disease, strokes, and heart attacks. And so Celebrex can also have that issue with increased high blood pressure and concern with cardiovascular problems, but much, much, much less so than compared to Vioxx. And so that's why this medication is still available in the market. Similar to other non-steroidal medications, Celebrex can cause stomach ulcers and stomach bleeding. So we do have to be careful with that. And so that's why when patients are taking prednisone and Celebrex, we tell them to take something to protect their stomachs, like a proton pump inhibitor, an acid suppression medication to protect their stomach. And we always tell patients to take it with food so it can minimize the irritation on the stomach. We don't recommend this medication in people who have underlying kidney problems because it can worsen their kidney function. It can also increase risk of overall bleeding. And in patients who have allergies to sulfonamide or have aspirin-sensitive asthma, we usually caution against the use of this medication because they could develop allergic reactions. In terms of what we know in FOP, how it could be beneficial, it's really based on patients saying they felt better taking it. It's a pain medication, and FOP is associated with pain. And because it's an anti-inflammatory medication, we do recommend it, and so patients do take it. So it's really potential use is because of inhibiting the inflammatory prostaglandins. And so it provides symptomatic relief during flare-ups, and we sometimes use it chronically in people who have chronic joint pains. We also recommend patients take a break from it, so not to take it all the time, and we sometimes recommend taking a break from taking Celebrex. But there's really no published data in a mouse model with FOP or even human clinical trial models. Next slide. So the next two slides are going to be on bisphosphonates. I did talk about them briefly yesterday during my talk. The two drugs that I'm going to be highlighting are pamidronate, and then the other one is zoledronic acid. So pamidronate is a bisphosphonate that is given intravenously. It is not approved per se for osteoporosis, but we do suspect that it would help also bone health. Its now current indications are for treatment of hypercalcemia, as well as certain bone cancers and Paget's disease, which is a disease of the bone where patients have benign bone tumors. It is approved in both the pediatric as well as in the adults. In the pediatric doses, it's given weight-based, and it's given as a slow infusion over 4 to 5 hours, and it's given over 3 days. So it's a pretty laborsome infusion. Patients, especially the kids, are usually hospitalized when they're getting the infusions, and their calcium levels are monitored closely. The adults, the dose is standard of 90 milligrams, but it's also given intravenously, and it's also given over 3 days. With the bisphosphonates, some of the side effects that we worry about is lowering of the calcium level and causing low calciums. And that's why we always make sure our patients have adequate calcium intake, their serum calcium is normal, and that their vitamin D levels are normal. Intravenous bisphosphonates are associated with flu-like symptoms, so patients feel just unwell, muscle aches, low-grade fever. We don't recommend bisphosphonates in people who have moderate to severe renal insufficiency. And there's some other rare side effects that have not been reported as far as I'm aware in FOP. And these are extremely rare side effects, extremely unlikely to happen. But one of them is the osteonecrosis of the jaw, which is basically where the jawbone is exposed and doesn't heal and can get infected. And then the other one is a stress fracture that can happen in the thigh bone that's referred to as an atypical femur fracture. And both of those side effects usually occur in patients who are getting higher doses and they're on it chronically for a longer period of time. It's extremely unlikely to see that after a single course or a single dose of pamidronate. In terms of theoretical benefit in FOP, I really think that most of the reasons why we use bisphosphonates in FOP is really to protect the normal bone, so the bone in the right place, from the negative effects of steroids. And we really try to use it to decrease risk of fractures and improve bone health in FOP patients. And so the times that pamidronate might have been prescribed to your children or to you is in the times of someone having relentless flare-ups, like a hip flare-up where we've given the first course of steroids and then a second course of steroid with even a longer taper. So it's been several months of being on high doses of steroids, of prednisone, and we would recommend to give pamidronate to help protect the normal bone. There is a possibility that, that it can play a role also in decreasing inflammation, as maybe also decreasing the blood supply to the area of active bone formation. But we don't have any data to support that. And in terms of published data, there's really nothing published in an FOP mouse model or even in terms of case reports in FOP patients. Next slide. So the other bisphosphonate, it's called zoledronic acid. It's so much easier to administer because it's given less frequently, and it does have the indication for treatment of osteoporosis, as well as for treatment of high calcium disorders and certain cancers. IV zoledronic acid can be given in children as well as in adults. In children, it's also weight-based, so it depends on the weight, but it's given more frequently in children. It could be anywhere from every 3 to 6 months. But in the adults, we use it usually once a year as an infusion. And it's not a lifelong medication, so we do like short courses of this medication. So it's not like a once a year for the rest of your life. I think in FOP, it would be just a one-time thing when someone's actively having a lot of flare-ups and we have concerns about their bone health. Very similar to pamidronate, it has a very similar side effect profile with a lowering of the calcium levels, flu-like symptoms, renal insufficiency, and the side effects of the osteonecrosis of the jaw and the stress fracture in the thigh bone. And also a very similar theoretical benefit in FOP. So it's an either-or option. So it's not like both. You either do pamidronate or you do the zoledronic acid. Next slide. Now I'm going to go over imatinib, which is called Gleevec. Imatinib has been used as approved for treatment of cancers as well as childhood cancers, and approved in GI cancers, leukemias, as well as a condition called mastocytosis, which is a condition where there's a high amount of mast cells, which is also something we think FOP, lesions or the inflammatory process can involve also some mast cell disorder. It is the advantage also of imatinib is that it's given as a pill. So a lot of our FOP patients love things that they can take orally and not as an injection. And the other thing is it's approved again in cancers in children as well. So we can use it in children. We have safety data on its use in children. I'm just highlighting some of the doses. Again, in children, it's usually adjusted based on their size, and then in adults, it's more of a standard dose. And again, if you review to the published treatment guidelines on the iccfop.org website, you can get a lot more detail in terms of the dosing of this medication, as well as what are the things that we monitor for. But some of the side effects that have been seen with imatinib is GI side effects, so nausea, vomiting, decreased appetite, weight loss. It can negatively affect the kidney function as well as the liver function, and it can increase risk of infections by lowering the white blood cell count. So we do recommend monitoring of these parameters on a regular basis. With imatinib, we actually have the theoretical benefit of how imatinib works and some of its off-target effects on decreasing HIF-1 alpha, which is involved in hypoxia, which we know that this is part of the early inflammatory involvement in FOP. And so we had, there is some theoretical benefit in its use. And in an FOP mouse model that was published in JBMR, sorry, this is a typo, it's 2016, not 2026, where, this was looking at the hypoxia, the involvement of hypoxia in the flare-ups and development of bone formation in FOP mouse model. And as part of that study, imatinib was used, and that seemed to decrease markers of hypoxia and also decrease bone formation in the FOP mouse model. And so based on that data and based on this availability in children and understanding of its safety, it was used off-label in 7 children with FOP that were having relentless back flare-ups. And these back flare-ups would not go away, were extremely painful. It was months and months, almost a year of having these painful flare-ups in their back that was affecting their ability to go to school. And it was very uncomfortable for them. And so as a desperate measure, imatinib was used. And if you look at that case series, the use of imatinib here to decrease the frequency of these flare-ups. And so Fred Kaplan published that in 2017. And then subsequently, some of these patients were taken off of imatinib and their flare-up rates went back up again. And then they were restarted on imatinib and the flare-up rates went down. And so Fred Kaplan published on those on-off, flare-up frequency with imatinib in 2021. We don't have any data that this decreases risk of bone formation. We need more studies to better understand the benefit. But right now, the times that we have recommended imatinib has been, as a desperate measure in children who keep having these relentless back flare-ups and they just don't seem to subside, and it's really affecting their quality of life. Next slide. So the last class of medications that I'm going to be talking about are the interleukin-1 inhibitors, like canakinumab, I keep mispronouncing that, and anakinra. And so these are medications that are approved right now for the treatment of autoinflammatory conditions, so such as juvenile rheumatoid arthritis, in gout, and also during COVID was used in patients who had this hyperinflammatory response to decrease inflammation. These medications are administered subcutaneously every 4 to 8 weeks. And then with anakinra, it's more of a subcutaneous injection. As I mentioned, again, these are, approved in children. Because these medications decrease the amount of inflammation in the body or the body's ability to mount an inflammatory response, this will decrease the body's ability to fight infections. And also in patients who've had tuberculosis, that might get reactivated because of the body's inability to suppress the tuberculosis infection, and also can increase risk of patients developing the disease when they're given live vaccines. Because these medications are approved for a various spectrum of diseases, the side effects reported can vary quite a bit, but the most commonly reported side effects are cold-like symptoms, GI side effects like nausea, vomiting, diarrhea, and injection site reaction. I personally don't have any experience with the use of interleukin-1 inhibitors. I know Ed Chow probably has a lot more personal experience on the use of these agents in FOP. But in terms of what we know about theoretical benefit in FOP, was really based on a case report that was published in 2019 on a 35-and-a-half-year-old boy with FOP who was having relentless flare-ups in his back, about 4 to 5 flare-ups per month. And when they measured the blood sample, looked at the interleukin-1 levels, that was elevated during flare-ups. And while the child was on treatment, those levels of interleukin-1B levels were lower while on treatment, and that was associated with a decrease in flare-up frequency. And we already knew historically that interleukin 1b has been associated with increased risk of heterotopic bone ossification. Next slide. So I will just conclude my talk today looking at this graph on this 13-year-old boy with FOP who was having, flare-ups, anywhere from 2 to 4 flare-ups in his back monthly. And you can see when anakinra was initiated, the flare-up rate decreased substantially, was almost completely suppressed as well, and then was switched to canakinumab, and then the flare-up rates were still lower than they were at baseline, but maybe slightly higher. And then when that was stopped, the flare-up rate went up much higher, and so that was reinitiated. So that's the extent of information that we have. I'm sure maybe some of you in the audience probably have more experience than I do, and some of my colleagues might have a lot more experience with using these agents than I do. But those are the the medications that I'm highlighting today. It's, again, not comprehensive, and you definitely should always discuss with your primary care doctor, your local doctors, about what potential therapeutic options are available, and always refer to the iccfop.org website for updated treatment guidelines. And with that concludes my talk, and thank you for your attention.
Okay, thank you so much. So Dr. Scott is going to come join me on the stage, and then we'll also have our other panelists joining us. So Dr. Kaplan will be back on, and then we'll also have Dr. Eekhoff from Amsterdam, who joined us yesterday, and then we'll have someone new joining us this morning, and that is Dr. Carmen de Cunto from Argentina. She is also a member of the International Clinical Council on FOP and the Registry Medical Advisory Board. So we'll have a variety of people sharing with us and answering your questions this morning. So I've got a few questions, but we will look to the audience to hear your questions as well. Hope, I think, has a microphone, and I think Shay has a microphone over here too. So. Okay, well, welcome to our panelists. Thanks for joining us this morning. So I am going to start with one of the questions that came in online, and I'm going to actually direct it to you, Dr. Eekhoff. The question is, can I be taking one of these off-label treatments and also participate in a clinical trial?
Well, that's a very good question. But if you are taking, when you are participating in a trial, you can't use other medications because otherwise you can't interpret or assess the effect of the trial medication itself. So no, that's my answer. You can't take both. Yeah, that's my answer. I can also speak about taking medication that isn't in a trial, but that has been very well explained by Mona. And
okay, so you want to it sounds like you want to throw it to Mona, and it looks like Mona has her hand up too.
Yes, no, I think so. This is exactly why it's very important to discuss with your local doctors, and of course, that's a very good question about being in a clinical trial. To discuss with your local study team as well about drug-drug interactions and if certain medications are contraindicated. So, for example, because prednisone and Celebrex or non-steroidals are considered a standard of care, most of the clinical trials, at least right now, don't seem to they don't specify that as a contraindication. For the bisphosphonates, again, this is helping the bones, and so it helps strengthen the bones. The only times we've seen bisphosphonates be contraindicated is in people who are getting the sodium fluoride PET CT scan, because it can affect the results, the validity of the sodium fluoride PET CT scan. And so, certain ones, they might be contraindicated. Even for, cromolyn, some of the other medications that I did not discuss, some of these class 2 medications like cromolyn, that sometimes helps with the breathing, sometimes helps with the digestive systems, can be allowed. I mean, some patients might have asthma and they're on it for other indications. So it's not an automatic no, but like imatinib, yes, it's listed in a lot of the, this is the protocols that they say you're not allowed to be on imatinib, you're not allowed to be on interleukin-1 inhibitors. And so, yes, some of these off-label use medications cannot be used if someone is in a clinical trial, but it's not an automatic no. Some of them are allowed.
Okay. And another question that came in online
Maybe-
is, and I'll throw this to
Maybe
Dr.
if I can
Kapp.
add to Mona.
Oh, Dr. Eekhoff, I'm sorry, did you want to say something else?
Yes, I think I have a bad connection, so you can't see me anymore. I want to add to Mona. Mona gave a very nice division in type 1, 2, and 3 medication, isn't it, Mona? And I think you can say that at the level 2, that is not allowed in most cases. But 1, yes, you can use.
Okay, that's a great clarification. Thank you. So the question, we talked a lot about, I think Dr. Scott talked about it, Dr. Al-Makram also spoke about it, about connecting your local doctor to an FOP expert. So Dr. Kaplan, I'm going to ask you, how is the best way if a family sees something online and they want to try something, how's the best way for them to connect their local doctor to an FOP expert?
I just want to thank you for that question. Just want to acknowledge the fact that there's 5 people on this video, and that's about 1/4 of the membership of the International Clinical Council on FOP, the experts on FOP. Those are we're all listed. Our contact information is all listed in the clinical guidelines, which are available on the IFOP website and also on the ICC website. So every patient should have access to that. All of the members are extremely receptive to questions about FOP. And I think what Mona said and what Chris said are extremely important. We battle this every day. Patients contact us and they say, well, can we get this medicine and what should we do? And we're having a flare-up. And we ask them, do you have a clinical doctor? Do you have a primary care doctor in your area? No, they don't want to deal with FOP. And our response is always, they don't have to deal with FOP. They can talk to us. They can contact any of us that they feel comfortable with. And we'll give them information on FOP and we'll guide them. We'll be shepherds in guiding them on the FOP questions they have. But we tell the patients, you need a doctor locally to take care of you, to be eyes on the ground, to be a general on the ground if there's a war. Basically, when I say a war, I mean, is there a flare-up? We want somebody to take a look at the patient. Is it really a flare-up? Do they have something else? Yesterday, we talked about superior mesenteric artery syndrome. Patients who have FOP can have anything that everybody else has. They can have colds, they have sore throats, they can have rheumatic fever, they can have tonsillitis, they can have appendicitis, etc. So you need a general doctor. And I think the message to the patients that we have and that should be broadcast around the world is you don't need an FOP expert locally. You need a general doctor who's willing to know that you have FOP and will contact us with any FOP questions. That's the essence. And then we have a team effort. When the patients contact us and say, I'm having really bad pain in my hip or really bad pain in my belly or my arm, what should I do? The answer is we can't answer their questions unless we have a doctor on the ground who can see the patient, who is there, who can see that patient. So it's the patient's and the family's responsibility to find that general practitioner in their local area who is willing to know that they have FOP and contact us if they have any problems.
Yeah. So to be your own advocate, to say, I want you to call my
Absolutely.
doctor. I want you to call the FOP expert. Here's how you find them, and really continue to push for that is so important. Yeah. thank you.
Absolutely, absolutely. And the doctor who's their local doctor, as Chris said, knows the patient in times of health as well as when they're not feeling well. And so they can assess, things that we can assess over the phone. And also from a license standpoint, we can't practice medicine in different countries. We can't prescribe these medicines. They need a doctor who is local, who can prescribe the medicines after talking to us. And we're only a Zoom call away.
Yeah, that's great. Hope, did you have any questions out there before I jump on? Did you? Oh, sorry.
We will get to this. Oh.
Okay, go ahead, Lori.
I had a question about permethrin and the side effects of it and how long they last, as far as affecting the jaw and bone healing. The reason I say that is Erin had permethrin some years ago, and it was mentioned to me that it might affect her bone healing later on, and I was just wondering how long it stays in the system.
Mona, I think we're going to direct that question to you.
Yeah, kind of figured that one. Yeah, so I think the risks are really low when it comes to any problems with osteonecrosis of the jaw. But the medications like permethrin and zoledronic acid can stay in the system, can stay in the bone for a long time because the way they bind. They're not, and if you do a blood sample, you're not going to find it there. But their effects on the bone can, linger on for months to maybe a year or 2 years. But again, even though the effects of these medications can linger on for months, the side effects are very minimal. So I wouldn't really be that concerned about, if you need to do any dental work or dental extractions and it's been over a year from when you've received those medications, that should not be an issue.
Okay, thank you. So there was a question that was raised online about, moms compare with one another and they say, my child was given this, and then someone else says, but I got a different answer. My child was given this. And so I don't know if Dr. DeCunto or someone else wants to speak to, when we see that our kids all have FOP and we think we're talking about the same kind of flare, we get different answers. So maybe you could share a little bit about that.
Okay, well, thank you. First of all, thank you for the invitation to be part of this session. Yes, we have to know that we know that for different type of flares, we can recommend different drugs and different approaches depending on the location of the flare, and maybe it can be a flare on the back, and we can manage only with a non-steroidal drug. But it is in the hip or in the jaw, we are really pressed to use steroids to try to avoid the inflammation in a better way. So that's a pain. But also it can be difference between the doctors that order things for different kids. And so I don't know specifically what drug they were really mentioned. But I think mainly sometimes our differences, for example, to treat pain, chronic pain. And
Right.
that's really that's a big problem because we start with the lower type of medications that can not do harm, but they can help, and we see the response of each patient to each drug. But sometimes we have to escalate to more important painkillers. So, and that is specific for each patient.
And thank you. I think that's terrific. And we also need to say that the guidelines are guidelines. They're not rules. They're guidelines. And this is again, we go back to the local doctors. Everybody is different. We know that there's a wide spectrum in terms of severity of FOP. Some people are more mildly affected, some are more severely affected. Even on identical twins, and I've had the honor and opportunity to see 3 pairs of identical twins who have FOP around the world, and even among the pairs, even in the pairs, they're different. So treatment for one may be a little different than for another. And somebody might, like you said, Carmen, might have more pain, and you might prescribe one medication for this individual, and maybe a medication doesn't work. I mean, even great medications don't work. And, take penicillin, for instance. It's a great medicine, but some people are allergic to it. You can't use it. And again, the tolerance for medicines, the individual doctor, the guidelines are not rules, they're guidelines. And so there are definitely going to be differences in the treatment among patients. But I think the main umbrella is that all the things we're talking about today are symptomatic relief. They're not, they're not clinical. Chris talked about clinical trials, but we're talking about the symptomatic relief. And we want to make patients feel better. What makes them feel better? What makes them more functional? And basically, what does this mean for me as a patient? And the answer to that question is going to be different for different patients.
Yeah, that makes sense. Well, thank you so much for sharing with us about the things that we see being discussed and having these conversations that help us learn to be our own advocates and to connect them to the resources that are available from you all and from the IFOPA as well. So thank you so much.